So the next topic is liver transplantation. In cases of chronic liver disease or cirrhosis, whenever the liver disease is irreversible, then in cases of complications, we need to perform a liver transplantation. We need to remove the liver and we have to replace the liver with a new liver taken from another donor, and this procedure is known as liver transplantation. Okay. Now, the Human Transplantation Act was passed in which year? In 1994. Okay. So the Human Transplantation Act was passed in 1994, and there are various types of grafts. Okay. The various types of grafts are autograft, isograft, allograft, or homograft, heterograft, or xenograft. Okay, these are the types of grafts. Okay, now what is the definition of each type of graft? This has been asked in MCQs in previous years. Okay, so the autograft is, we have taken the graft from the same individual from one side and we have attached it to the other side. Okay, take patient own tissues are used. Okay, that is autograft. Isograft is when it is being taken from the identical twins. Okay, from the graft taken from identical twins. This allograft is when it is taken from the same species. Taken from same species. And heterograft is when the graft is being taken from different species. Okay. So this is important. In autograft, we are using patient's own tissues. In isograft, we are using graft from the identical twins. In allograft, which is also known as homograft, we are taking the graft from the same species. And in heterograft or xenograft, the graft is being taken from the different species. Now, it is being asked that liver transplantation is a type of allograft. Okay, because we are taking the liver from another person who belongs to the same species. Okay, from another human being. Now, liver transplantation is of two types. We are doing diseased liver transplantation, or you can say deceased donor liver transplantation, where we are taking the organ from a person who is dead or brain dead per se. Okay, and the next is live donor liver transplantation, where the person is alive and is donating portion of their liver. Okay, so this DDLT stands for deceased donor liver transplantation, and LDLT stands for live donor liver transplantation. The full form of these has been asked. DDLT stands for deceased donor and LDLT stands for live donor liver transplantation. Now, obviously in DDLT we can take whole of the liver, and in live donor we will be able to take only a portion of the liver. Okay, So in live donor, we will be able to take a portion, or you can say a segment, uh, or few segments of the liver. Okay. Most commonly in a live donor liver transplantation, we are performing right lobe liver transplantation. We are taking right lobe as a graft, followed by left lobe. In pediatric liver transplantation, the left lobe is taken more frequently. Okay, whereas in adult to adult liver transplantation, we are taking mainly the right lobe. And most commonly in the diseased donor or the dead donor liver transplantation, we are taking whole of the liver when we are doing it for the adult. Okay. Now, who performed the first liver transplant? And who performed the first kidney transplant? This has been asked frequently. So the first liver transplant was performed by Starzl, and the first kidney transplant was performed by Murray in the year 1954. Okay. So this Starzl has been asked and Murray has been asked many times. Now, who performed the first pancreas transplant? And who performed the first islet cell transplant? So the first pancreatic transplant was performed by Kelly and Lilhy, and the first islet cell transplant was performed by Sutherland. Okay. Now, the first heart transplant and first lung transplant. So, the first heart transplant was performed by Christian Bernard, whereas the first lung transplant was performed by Fritz Derom. So, these Starzl performed the liver transplant, and this Murray performed kidney transplant, and Christian Bernard performed the first heart transplant. These three questions has been asked multiple times. Okay. Now, before going to discuss liver transplant, I'll first discuss the child Puck score or the child Puck Turcot score. This is very important. This is also known as CTP score. CTP stands for child Puck Turcot score. Okay. Now, why CTP is important and is related to liver transplant? Okay. Suppose if a patient is having CLD or a chronic liver disease with cirrhosis, these patients develop various complications. Okay. These complications are jaundice, GI bleed, ascites, hepatic encephalopathy, etc. Okay. So, based on these complications, if a person with cirrhosis is having various types of complications and is developing these complications repeatedly and is not resolving on medical management, then we need to perform liver transplant in these patients. Now, to grade the severity of the disease in the cirrhotic patients, whether the patient is having mild cirrhosis or is having a severe cirrhosis, we need to calculate their CTP score. Okay. Now, if a patient is having severe cirrhosis with various kind of complications, in that patient we'll have to go for a liver transplantation. Now, what all are the components of this CTP score? So, this CTP score can be remembered with a mnemonic. The components can be remembered with the mnemonic BAPE. Okay. So, the components are bilirubin, ascites, albumin, prothrombin time, and encephalopathy. Okay, and we are giving score 1, to 3. Okay. Now, for if a patient is having bilirubin of less than 2 milligram per deciliter or 2 to 3, more than 3, the site is absent, slight, moderate, albumin more than 3.5, 2.8 to 3.5 or less than 2.8, PT or you can say INR, if INR is less than 1.7, 1.7 to 2.3 or more than 2.3, and if encephalopathy is absent, encephalopathy is grade 1 to 2, that is mild to moderate, or if encephalopathy is grade 3 to 4 or severe encephalopathy, then we are going to give 0.3. Okay. Now, the minimum CTP score can be 1 in all of these 5 categories. So, the minimum CTP score can be 5 and the maximum CTP score can be 15. Okay. So, another question, CTP score ranges from 5 to 15. Now, the way I have remembered is that the patient having moderate or a class B CTP score is between 7 to 9. Okay. So, any patient who is having a CTP score of in between 7 to 9, then it is class B. If it is less than 7, then it is class A, and if it is more than 9, then it is class C. Okay. So, the class A CTP score is when it is 5 or 6, class B is when it is 7 to 9, and class C is when it is 10 to 15. Why calculation of the CTP score is important? Because we can predict a 1-year survival by calculating a CTP score. So, what is the 1-year survival? A patient who is having a class A score of 5 to 6, then the 1-year survival is close to 100%. Here the 1-year survival is close to 80% and here it is 45%. Okay. So, if a patient is having severe serotic complications, then there is a class C child book score, then there is a probability, more than 50% probability of dying in the next year or within a year. So, these patients need urgent or early liver transplantation as compared to the other serotic patients. Okay. Now, what is the most common indication for liver transplantation overall? Or worldwide, you can say. The most common indication is cirrhosis. Okay. Now, if we'll go, the cirrhosis can occur due to various causes. It can occur due to alcohol, hepatitis B, hepatitis C, or other reasons also. Okay. So, out of all these reasons, the hepatitis C virus induced cirrhosis is the most common indication for liver transplantation. Okay. And second most common is, or the second most common indication is alcohol induced cirrhosis. Fine. Now, in a pediatric age group, the most common indication is biliary atresia. Most common indication for liver transplantation in pediatric age group is biliary atresia. That is malformation of the congenital malformations of the bile ducts, biliary atresia. And among the various metabolic disorders, the most common metabolic disorder requiring liver transplantation is alpha 1 antitrypsin deficiency. And in acute liver failure, which is not responding to the medical management, or very severe acute liver failure that can be life threatening, we may need to perform a liver transplantation or urgent liver transplantation. And what is the most common cause of acute liver failure? Most common cause of acute liver failure requiring liver transplantation is acetaminophen toxicity. And how we can identify whether a patient of acetaminophen toxicity require a liver transplantation or require a medical management? There is a criteria on the basis of which we can decide, and the criteria, name of the criteria is King's College criteria. Okay. Okay. Now, suppose the patient is having cirrhosis. So suppose this is a normal liver. A cirrhotic patient will be having a shrunken nodular liver that is damaged. Now, what we need to do while performing a liver transplantation, we first remove the diseased liver. Okay, that is known as recipient hepatectomy. That where a person who is receiving the liver is the recipient, and the person who is donating the liver is the donor. So, in the recipient, first we have to remove the liver, which is known as recipient hepatectomy. From the donor, we will take a liver graft that can be a partial graft or a complete graft. Okay, based on the whether the patient is a deceased donor or whether it is a live donor. Okay. So this procedure is known as donor hepatectomy. And after taking the graft, in this empty space, we will have to place this graft in the recipient, which is known as implantation of the graft. These are the surgical procedures done while performing a liver transplantation. So, here we are removing diseased liver. Why we are removing the diseased liver? Because there is a possibility of developing SCC. And also we need to connect the arterial and venous drainage and the biliary drainage. So, develop and creating the anastomosis at the native place is more easier. And also there is a possibility of developing SCC. So, we remove the recipient liver. So, we remove the damaged liver, you can say. So, if we have removed the damaged liver and now we are placing another liver at the same site. So, this is a damaged liver. Now, we have removed the damaged liver and now we are putting another liver on the same site. Then this is known as orthotopic liver transplantation. Okay. So, orthotopic liver transplantation is placement of graft at normal anatomical site. In kidney transplantation, suppose a patient is having chronic kidney disease, what we do generally is we take a donor's kidney and we place it in the iliac fossa and we attach the arterial, venous and the urinary drainage or the ureter, and this is not in the anatomical position. So, generally the kidney transplantation is not performed at the native place, native or a normal anatomical site. So this is known as a heterotopic transplantation. So now you know two terminologies: orthotopic at the same place and heterotopic at a different place. So liver transplantation is mainly orthotopic and the kidney transplantation is mainly heterotopic. Okay. Now there are other types of transplantation also. This DDLT or the disease donor liver transplantation I have told you. Then LDLT or live donor liver transplantation I have told you. Okay. Now there is one auxiliary liver transplantation. What we do in auxiliary liver transplantation, suppose there is a liver here, if we put a graft adjacent to that, but we are not removing the diseased liver, then this is known as auxiliary liver transplantation, because we are not placing the graft at a very distant place, we are placing the graft adjacent to the native place. Okay. So the placement of graft near the organ bed without removal of the diseased liver. Then this is known as auxiliary liver transplantation. And suppose if we are removing partial liver, suppose this is the normal liver or the normal native diseased liver, if we are removing partial liver here and we are placing a graft here, so then this will be known as auxiliary because it is near the organ bed and also it is partial orthotopic liver transplantation. Okay. Or in short form that has been asked previously, APOLT stands for auxiliary partial orthotopic liver transplantation. Here we are placing the graft. Placement of graft is done at the space which is created after, you can say, partial excision of the native diseased liver. Okay, so this is regarding APOLT, also known as auxiliary partial orthotopic liver transplant. Now, what is a split liver transplant? Okay. Suppose there is a deceased donor or a dead donor. From the dead donor, we have taken whole of the liver. And now we are having two recipients. Preferably one adult recipient and one pediatric recipient. So what we can do is, we can split the liver into two. The right lobe we can give it to the adult and the left lobe we can give it to the pediatric. Okay. So this way one graft can be used for two recipients and both of the recipients can be benefited with the same graft. And suppose in a pediatric recipient having age group of 6 months, okay, and because of biliary atresia, it requires liver transplantation. Now the mother is donating the liver. The size of the graft is quite big, and suppose if we are taking left lobe from the mother, then suppose the volume of the left lobe is 350 grams. The child require 150 grams only, because the child is very small. Okay, so in that case, what we need to do, we need to reduce this big graft to a smaller graft so that it fits into the abdomen of the child and it met the requirement which is needed for the child. Okay, so this reduction of graft size is called as reduced liver transplant. No, it's called as reduction of graft or reduced liver transplant. Okay, so here we are benefiting only one recipient and we are reducing the size of the graft from the large size to the smaller size to fit for the pediatric recipient. Generally, it is required, the reduction of the graft is generally required in the pediatric age groups only. Okay, and what is the piggyback liver transplant? What is a piggyback liver transplant? Normally, in a deceased donor liver transplant, what we are doing, we are removing the liver with part of superior vena cava and inferior vena cava, and in the you can say in the recipient, we are removing the liver with the IVCs. Okay, in a deceased donor or a dead donor, we are removing the liver with the IVC, and in the recipient who is alive, we want to implant this graft. So we remove the IVC of the graft of the recipient. Now, if we preserve the IVC, of the recipient while we are performing the recipient hepatectomy, okay, so this you try to understand. Suppose if a patient is requiring liver transplant and we are removing the liver from that patient and we are now planning to implant another liver which is taken from a deceased donor. So what we are doing is while removing this deceased liver, we will remove the IVC along with that, and while performing we'll have to perform both caval anastomosis also. So in the meantime, we'll have to put the patient on bypass so that the blood goes from the superior vena cava to the inferior vena cava circulation and it goes towards the heart. So this caval preservation or IVC preservation helps in decreasing the hemodynamic disturbances. Okay, so that is why this preservation of IVC concept came, and this, if we preserve this IVC here in the recipient, then we'll have to do a cavocavostomy, the donor IVC, anastomosis of the donor IVC with the recipient IVC. Okay, we will not do superior vena cava anastomosis separate and inferior cava anastomosis separate. We can do, this IVC is here behind, we can do in between IVC and IVC the anastomosis. Okay, so this decreases the hemodynamic disturbances, and this IVC preservation in recipient, okay, is known as the piggyback type of liver transplantation. Okay, and now what all are the indications? I have told you APOLT, auxiliary partial orthotopic liver transplantation. So what are the indications for APOLT? Just first I'll explain and then I'll enumerate. Here we are doing partial excision of the native liver and we are putting a graft. Suppose if there is any metabolic abnormality or acute liver failure, the liver just need time to regenerate. Okay. So, but otherwise the liver is okay. There is no chronic liver disease changes. So what we can do? We can do a partial liver transplantation, and this partial liver will help the patient in surviving that acute episode, and gradually the native liver will regenerate or will improve, and the benefits or the long-term immunosuppression might not be required for the patient. Okay. So this is the concept behind APOLT, and the indications are acute fulminant reversible liver failure. This is the most common indication. Second is small for size graft. Suppose we have performed a live donor liver transplantation, but this live donor graft is not able to compensate for the need of the whole body of the recipient. Then we can add another small portion of the liver to improve the outcomes. Okay. Then the third is non-serotic metabolic liver disease. And the fourth is ABO incompatibility. Okay, why we are using APOLT in the non-serotic metabolic liver disease? Because otherwise the liver is normal, it is producing albumin and it is doing the other functions of the normal liver. So we don't want to remove that normal liver. But there is some problems like in some metabolic liver disease. So to compensate that particular portion of the liver function, we can add a smaller graft, and otherwise rest of the functions can be managed with a normal native liver. Okay, so these all are the indications for APOLT. This acute fulminant reversible liver failure has been asked, and it is the most common and the most important indication for performing APOLT. Okay, now a summary of what I have explained in the liver transplantation. Just see here, this is the conventional technique of DDLT, okay, or the diseased donor or the dead donor liver transplantation. Okay, what is the conventional technique? Just see here, the native liver or the diseased liver has been removed. Now we have placed another liver with the superior vena cava and IVC. Here we are anastomosing here and here normally. The portal vein and hepatic artery and the bile duct has been anastomosed normally. Okay, so these are the other anastomosis: portal vein, hepatic artery, and the bile duct anastomosis. So this is normal pattern. Whereas in piggyback, you can see here there is no anastomosis both at the superior vena cava end and the inferior vena cava end. The IVC which is in the donor liver and the native IVC has been anastomosed together. This is piggyback technique. Okay. Now, suppose if whole of the deceased donor is being divided into two portions, then this is split liver transplant, and they are given to two different recipients. It is a variant of DDLT. In this LDLT, we can do both right lobe liver transplant. We can take right lobe graft also and left lobe graft also. So suppose if we are taking a right lobe graft, here in this diagram we are taking a right lobe graft. So this right lobe graft is given to the recipient, and this left lobe graft left lobe stays in the donor. Okay. Here in the split liver, here you can see this adult right graft is given to the adult, and this small left one is given to the pediatric. Okay, so this is basic understanding of the liver transplantation. Now another important question. Suppose I am having a liver cirrhosis and there is another person who is having a liver cirrhosis. So out of two of us, who is getting the liver first? Okay. Suppose in majority of the Western countries, they are performing DDLT. Okay. Only they are taking liver, or preferably they are taking liver from the dead donors. Okay. Or from the brain dead people. Now, there are a lot of patients who require a liver transplant, but the number of organ pool or the number of grafts are very small. So, to give this, how to give this small number of graft to this large population of the cirrhotic patients? They have devised a method for organ allocation. So, who will be having higher score will be ranked higher and will be given the graft first. Okay. So, this ranking system of organ allocation is known as MELD score. Okay. For pediatric, this is known as PELD score. So, the question is organ allocation for DDLT is based on MELD score for adults and PELD score for children's. Okay. Now, what is the full form of this MELD score? This is Model for End Stage Liver Disease. Model for End Stage Liver Disease. Okay. So, this helps in organ allocation in UNOS, United Nations Organ Sharing Network. Okay. Now, what all are the criterias? The mnemonic is CBI. It is creatinine, bilirubin, and INR. Okay. Creatinine, bilirubin, and INR, and it ranges from 6 to 40. So, a person who is having a higher MELD score will be given preference for organ. Okay. Whereas this PELD score is for pediatric population. I'll write it. This PELD score stands for pediatric end stage liver disease. Okay. And the mnemonic is NABIA. It is nutrition, age, bilirubin, INR, and albumin. Okay, it is nutrition, age, bilirubin, INR, and albumin. So, it is important to understand bilirubin and INR is same. So, in pediatric end stage liver transplant or PELD score, all of the following are the criteria except they generally give creatinine in the option. So, creatinine is for MELD score, whereas in PELD score, the importance is of age and nutrition also. Okay, and albumin also. Okay, so this is important. Now, if a person is having acute liver failure, and whether liver transplantation is indicated or not, and this is based on King's College criteria. Now, most commonly this acute liver failure is because of acetaminophen toxicity, and most common cause of acute liver failure due to any medicine is acetaminophen toxicity, and most common cause of any drug toxicity which requires liver transplantation is acetaminophen toxicity. So the important thing is to understand that this King's College criteria is different for acute liver failure due to acetaminophen toxicity and acute liver failure due to any other etiology. So these are two King's College criteria separate. So first we'll see this acute liver failure due to acetaminophen toxicity here. If there is severe acidosis or the lactate is very high, then we will go for a liver transplantation. Or if all the three things occur, like there is significant hepatic encephalopathy, the creatinine is very high, or the INR is very high, that is more than 6.5, okay, then we are going for this liver transplantation, okay. This is in acetaminophen toxicity. In other etiologies, either INR will be more than 6.5 and hepatic encephalopathy is present, irrespective of any grade, then we are going. Generally, the questions that they ask is related to these points. So it's related to these points. Age less than 10 or more than 40, jaundice which is more than 7 days before development of encephalopathy, and INR more than 3.5. Okay, this is the point which is important to understand. Majority of the questions they will ask in non-acetaminophen related toxicity. What they will do is they will make it something like that, that age is more than 10 year or less than 40 year in the option, or they will say that jaundice is less than 7 days or within 7 days. Okay, what a general tendency to think is, suppose if there is any acute liver failure due to any problem, okay, if the jaundice is occurring within 7 days before the development of encephalopathy, then this is very severe, okay, but it is opposite. If the jaundice is more than 7 days before the development of encephalopathy, then we'll go for this liver transplantation, and here the INR is 3.5. If the INR is more than 6.5, then we'll straight away go for a liver transplantation. The next